As you know, epilepsy can be an incurable disease that affects people's lifestyle, their quality of life, and has significant medical morbidity implications. For patients with refractory epilepsy, often there's not a straightforward answer to stop their seizures. In those most difficult patients, we often have to do investigations that include things such as MRI scan, video EEG, ictal SPECT studies, magnetoencephalography, PET studies, neuropsychological studies. All of these things are put together to form a hypothesis about where a patient's seizures may come from. Once we have that hypothesis, then we need to prove whether our hypothesis is correct or not. And in order to do this, this requires investigations of the brain tissue itself. Historically, we have done many investigations using subdural grids, electrodes, and strip electrodes placed in the subdural space. More recently, we're using a technology called Stereoelectroencephalography, or SEEG, to investigate deep structures. And we do this in a more minimally invasive manner than we have done in the past with grid electrodes. For the SEEG cases, the electrodes are placed stereotactically and percutaneously. The electrodes do go into brain tissue, so there is a risk of bleeding anytime an electrode is placed, but that risk is very, very low. All the planning that we do is aimed to maximize the safety of the electrode implantation and avoid vascular structures. Once we've placed the electrodes, we have the benefit of placing multiple electrodes. We can investigate numerous lobes of the brain, frontal lobe, temporal lobe, parietal lobe. We can also do bilateral investigations. These extensive types of investigations are not quite as feasible with subdural electrodes, and that's one of the things that makes SEEG really ideal for our difficult candidates. Another ideal thing about the SEEG electrodes is that they can stay in place for a longer time. They are secured in the skull with a small bolt, which prevents CSF egress, and so the patients can stay in the epilepsy unit more than a week, and we have the opportunity to record seizures, sometimes multiple seizure types, which can be useful in developing a treatment plan. Once we've obtained sufficient information from the SEEG electrode recordings, then the electrodes are removed. Typically, the patients are discharged home. We spend time at our surgery meetings discussing surgical options, and then hopefully the patient is able to return for the second stage of treatment, which may be a resection of their seizure focus or may be a treatment procedure such as modulation with NeuroPace, which is responsive neurostimulation. These options obviously depend on what we find with the SEEG investigation, but we certainly have found that the ability to do SEEG investigations has broadened the category of patients that we're able to help from a surgical standpoint. Here at UAB, we have obtained the ROSA Robot, which is a device which allows us to very safely, efficiently, and precisely place the stereo EEG electrodes. The robot does not place the electrodes itself. I, as a surgeon, actually do the electrode placement, but the robot allows me to efficiently move from one electrode trajectory to the next, making it a shorter procedure for the patient. And because of the robotic precision, the human error that is possible anytime we have multiple trajectories or axes we're looking at, that human element is taken out of the trajectory placement, and so the robot really helps with that. So NeuroPace is the name of the FDA-approved device, which is available now in the United States to offer responsive neurostimulation to patients with epilepsy. Patients that are candidates for NeuroPace are patients who have refractory epilepsy who are not candidates for a curative surgical resection. In order to be a candidate for NeuroPace, patients have to be investigated, and we have to know exactly where their seizures come from. The NeuroPace device offers a couple of different options. The device is actually implanted within the brain, and then the generator is implanted in the skull. The device in the brain consists of either a depth electrode or a strip electrode that covers the area of seizure onset. These electrodes are then connected to a generator which is implanted in the skull. 2 electrodes can be connected at one time. The system allows to place 2 additional electrodes at the time of initial implantation, but only 2 electrodes can be actually connected to the device. Once the electrodes are connected to the device, which again is implanted in the scalp is closed up, and the device actually records electrocorticography from either deep in the brain if it's a depth electrode, or from the cortical surface from a strip electrode. The epileptologist then monitor that electrocorticography and set different paradigms of stimulation, hence the term responsive neurostimulation. And the goal of the device is to improve the patient's quality of life by diminishing seizures. It is generally not felt to be a curative device, more of a palliative device, but certainly there are categories of patients who can have a very profound response to the system. And again, these are patients that don't have an option for a curative resection. We've implanted a number of patients here and have had some very good results with the NeuroPace system. Often physicians wonder whether a patient might be a candidate for surgery, or frankly, many physicians either don't consider their patients to be surgical candidates, or think that because their patient only has 1 seizure a month, that they don't need surgery, that surgery is only for the most severe cases, and that's completely not the case. So 1 seizure a month is too much. If you have 1 seizure a month, you can't drive a car legally in the state of Alabama. You may be able to hold down a job, but the fear of having a seizure may affect your ability to keep that job. If you're a butcher, it's not a good idea to have a seizure once a month at work. So I would encourage referring physicians, if they have patients in their practice, really to consider any patient who has seizures despite medication for an evaluation, potentially for surgery. Obviously, not every patient is a candidate for surgery, but that decision is sometimes a nuanced one. And here at UAB, we really want to be part of the team to help make that decision. And if a patient doesn't come through the doors here, we can't help to decide if they could potentially be cured with surgery. Physicians as well sometimes have an idea that surgery is the end of the road and that it's a last resort, and we really want to think of it much earlier in the treatment paradigm. The goal is not to have it be the last thing we consider, but to consider it early, to try to have young patients continue to further their education, be productive members of society, and often we can do those investigations in a minimally invasive way, and surgery can be done very safely with a relatively short hospital stay and often a quick return to really fully functional and robust activities. UAB's epilepsy surgery program, I believe, is unique in a number of factors. Number one, we are a long-standing program with a very stable continuity of care. My predecessor, Dr. Richard Morowitz, did all the adult epilepsy surgery in the 80s, 90s, up to 2004. For greater than the last decade, I have done all the adult epilepsy surgery. So we have, a track record of consistent surgical care. On the epilepsy medicine side, we have very experienced epileptologists who are knowledgeable in numerous areas regarding epilepsy investigations. We're fortunate to have one of the most successful magnetoencephalography programs in the country. In fact, many people come from other centers here just to have their MEG studies performed because it's not a modality that is widely available, but we have found it to be very useful. We have an excellent track record with investigations such as ictal SPECT investigations. Our nurses perform those procedures more efficiently and with a better time injection following seizure than than many places that I've seen reported. We have a strong neuroimaging department, which is critical for incorporating the neuroimaging with the physiologic investigations. And then finally, we have a robust research program, which is behind the scenes but actively working to look for things that will impact our patients in the future, such as potentially a cure for epilepsy, improvement in patients' memory related to seizures, many different areas. So I think UAB offers a full spectrum in regards to epilepsy surgery and not just a simple surgical technique.